This video contains scientific and medical concepts aimed at informing healthcare professionals. Please note that the video may contain visually stimulating images and movement.
The content of this video series focuses upon the unique and pathognomonic clinical entity of ME/CFS known as post-exertional malaise, or PEM. It is now widely accepted that many cases of long COVID or post-acute sequelae of COVID-19 meet the diagnostic criteria for ME/CFS and likely represent cases of ME/CFS triggered by the initial and persistent immune response to a COVID-19 infection. PEM and PESE, or post-exertional symptom exacerbation, are thought to be the same clinical phenomena and can be considered interchangeable for the purposes of these videos.
Post-exertional malaise is an entirely unique and pathognomonic finding in ME/CFS. This physiological phenomenon has yet to be documented in any other illness, absent even in those suffering post-chemotherapy complications or within the most physically decompensated of ill individuals. While the lack of a biomarker specific for the diagnosis of ME/CFS may seem to pose an impediment to accurate diagnosis, a careful history eliciting the presence of post-exertional malaise, or PEM, remains highly specific for this illness and occasionally sheds light upon perhaps the most essential and universal pathology uniting patients suffering with ME/CFS. The Institute of Medicine defines post-exertional malaise as an inability to recover normally following physical, cognitive, or emotional exertion, resulting in an exacerbation of an individual's ME/CFS symptoms, leading to a reduction of functional ability that is more profound, more devastating, and longer lasting than observed in patients with other fatiguing disorders.
PEM is accompanied by a profound loss of stamina, reduction in functional capacity, and by augmented perturbations of ME/CFS pathophysiology, including worsening of autonomic dysfunction, metabolic efficiency, immune dysfunction, and aberrations in the HPA axis. Patients experiencing post-exertional malaise often describe an augmentation of flu-like symptoms, including subjective fevers, sore throats, myalgia, and arthralgia, worsening cognitive symptoms, including brain fog, difficulty with maintaining concentration, and word-finding difficulties, worsening insomnia, headaches, increasing sensitivity to sensory stimuli, such as light or sound, and/or exaggerations of their abnormal cardiovascular responses to upright positioning, also referred to as orthostatic intolerance. It is not uncommon for those experiencing the symptoms of PEM to remain confined to bed for much of the duration of their episode, often so functionally limited that they struggle to complete simple activities of daily living, such as toileting or eating prepared food. Exertional triggers that can elicit post-exertional malaise can include exercise, orthostatic stress, cognitive or mental activities, environmental stressors, including bright lights or loud or multiple sounds, or chemical exposures, and even emotional triggers, including both excitement and joy, as well as stressful or negative emotional responses. In fact, the word exertion may undermine the fact that basic activities such as reading a book, using a computer, engaging in conversation, showering, or even sitting up to eat a meal can be sufficient to trigger an episode of PEM among particularly ill individuals. A 2018 study queried 150 individuals diagnosed with ME/CFS regarding the triggers, time to onset, symptoms of, and duration of episodes of post-exertional malaise to help elucidate both the overlap and heterogeneity of each individual's experiences with PEM. Among those surveyed, over 90% of these individuals clearly recognized episodes of worsening symptoms consistent with the definition of PEM. Fatigue was universally recognized as the most commonly exacerbated symptom during episodes of PEM. Cognitive difficulties, sleep disturbances, headaches, muscle pain, and flu-like symptoms were all cited by at least 30% of the studied subjects. Integration of these distinct symptoms into general categories yielded a finding that 60% of subjects experienced at least one, if not multiple, inflammatory or immune-mediated symptoms during PEM.
Other notable symptoms cited by subjects included exacerbation of underlying orthostatic, gastrointestinal, neurological, and mood-related symptoms for the duration of their PEM episodes. Duration of episodes of PEM varied even among individual subjects themselves, likely as a consequence of the degree of overexertion triggering each individual episode. 84% of subjects, however, noted enduring PEM for a duration of 24 hours or longer.
Time to onset of an episode of PEM after an inciting exertional trigger yielded particularly diversified responses among subjects, though 11% reported a delay of at least 24 hours between their inciting trigger and the onset of symptoms of PEM. Despite this response data, clinicians who evaluate and treat those suffering with ME/CFS have almost universally recognized that the payback of PEM is often delayed by 24 to 48 hours from an initial triggering event. It is postulated that this discrepancy in data may arise from patients mistakenly interpreting the immediate worsening of symptoms of ME/CFS as a consequence of orthostatic intolerance for an actual episode of post-exertional malaise. In fact, many of those suffering with ME/CFS who additionally experience particularly aggressive symptoms of orthostatic intolerance may discover, upon adequate treatment of their orthostatic intolerance, that they are finally able to exceed a threshold by which they exert themselves sufficiently to induce a true episode of post-exertional malaise. In these instances, onset of symptoms of PEM are indeed delayed up to 24 hours after an initial exertional trigger. As if this delay between action and consequence were not already abundantly complicated, post-exertional malaise need not always be incited by one specific individual trigger. One particularly insightful patient has noted that she can instigate PEM by doing way too much all at once or by doing slightly too much over a span of several days. She reports that the duration and intensity of her symptoms of PEM are often more prolonged and exaggerated when she is struck by PEM as the result of only slightly exceeding her energy envelope for several days in a row. The phenomenon of variable intensity and frequency of triggers for PEM has often been likened to an analogy of debt. Consider, for example, that an individual with ME/CFS may have one metaphorical dollar of energy to spend each day. This individual could go on a spending spree, allocating upwards of $10 of energy expenditure in one day. This splurge might then be followed by an immediate requirement to pay back this debt, beginning the following day and extending until the entirety of the $10 is recouped and paid back. Alternatively, an individual could, perhaps unknowingly, spend $1.25 each day over the course of 2 weeks. While 25 cents of energy debt does not lead to immediate consequences, the accrual of this debt can become a substantial sum that, when PEM does arrive, must be paid back with interest.
Despite ME/CFS often being underdiagnosed in the absence of discrete diagnostic biomarkers, serial 2-day cardiopulmonary exercise testing, or CPET testing, has proven to be a reliable, reproducible, and accurate measure of post-exertional malaise among those suffering from ME/CFS. CPET testing has been used as a validated tool for assessment of functional capacity among healthy people, as well as among individuals with a multitude of debilitating and fatiguing illnesses. It is specifically designed to assess the coordinated contributions of metabolic, cardiovascular, respiratory, and muscular inputs to overall energy generation and utilization. When repeated 2 days in a row, variability among the multiple physiologic measurements obtained during CPET testing from one day to the next remains low among both healthy individuals and among those suffering from chronic illnesses. These illnesses include heart failure, COPD, end-stage renal disease, pulmonary hypertension, and cystic fibrosis, no matter how impaired they may be.
ME/CFS patients, by contrast, appear uniquely unable to reproduce their CPET outcome measures during serial 2-day testing, despite putting forth maximal effort. These individuals almost always display abnormal hemodynamic and respiratory responses during exercise upon a second day of testing that were not measured on day 1 of their serial CPET testing. CPET testing is particularly effective for measuring peak oxygen consumption, or VO2 peak, during exercise. VO2 peak has become a well-recognized indicator of functional capacity and as a surrogate measure of the maximum energy available for work. Individuals suffering from ME/CFS are found to be unable to reproduce their VO2 peak, reach their ventilatory threshold, achieve their peak workload, or duplicate their workload at ventilatory threshold attained on day 1 of CPET testing upon a second day of serial testing. CPET testing is also an effective tool for measuring the ventilatory anaerobic threshold, or VAT, as a function of assessing increases in muscle and blood pH, as well as detecting lactate and carbon dioxide concentrations. VAT is considered a reliable marker for detecting a patient's anaerobic threshold upon physiological exertion. CPET testing has demonstrated a notable reduction in ventilatory anaerobic threshold among individuals with ME/CFS, likely signaling a truncated ability to maintain aerobic metabolism and a resulting early onset of compensatory and less efficient anaerobic energy generation. Even among well-conditioned athletes, activity performed beyond the anaerobic threshold is rapidly fatiguing, cannot be sustained, and can trigger symptoms of fatigue, weakness, shortness of breath, nausea, headache, and/or muscle pain. CPET testing among those with ME/CFS not only captures a markedly low baseline anaerobic threshold, but serial testing on a second day additionally highlights further reductions in a ventilatory anaerobic threshold as compared to a day 1 baseline.
Many with ME/CFS thus appear to be operating almost entirely within the confines of anaerobic metabolism on the second day of serial testing, and as continued clinical symptoms suggest, may remain entirely anaerobic for several additional days beyond the completion of serial CPET testing. By way of comparison, healthy individuals that exceed their anaerobic thresholds during CPET testing will begin to recover within 10 minutes, rather than over the course of multiple days. Given the now significant body of evidence-based, literature-supported altered cellular metabolism, in addition to clear decrements in ventilatory anaerobic threshold and peak oxygen consumption in those with ME/CFS, one could presumably simplify their understanding of the varied and diverse triggers for PEM to cellular energy requirements. Skeletal, cardiac, and vascular or GI smooth muscle, as well as both gray and white matter of the central and peripheral nervous systems, may all function aberrantly in the absence of sufficient ATP to meet their immediate needs. Serial 2-day CPET testing has been clinically used to establish objective measurements supporting eligibility for disability benefits. In some cases, it may be crudely used to measure disease progression or severity. Despite these utilities, providers must weigh the benefits of CPET testing against its potential harms, which could include the induction of a prolonged worsening on an individual's ME/CFS as a result of the provocation of an extended episode of PEM.
Modified protocols of CPET testing have also been utilized as tools for research, specifically to evaluate gene expression and immunological responses to an exercise challenge. In one study, 20 patients with ME/CFS, 23 patients with multiple sclerosis, and 20 healthy controls were asked to use an exercise bike to reach 70% of their age and gender-predicted maximum heart rate for 25 minutes. Blood samples were drawn both before the exercise challenge and then again 30 minutes, 8 hours, 24 hours, and 48 hours after the 25-minute exercise challenge was administered. Gene expression as a function of measured levels of mRNA was investigated across sensory receptors commonly implicated in pain pathways, across adrenergic receptors, and across cytokine receptors located on leukocytes. While gene expression remained similar for the comparator groups at baseline, individuals with ME/CFS demonstrated significantly elevated expression of mRNA for adrenergic alpha-2 and beta-2 receptors, interleukin-10, and purigenic type 2X4 receptors within the post-exertional interval as compared to healthy controls and those with multiple sclerosis. A similarly structured study suggested that the magnitude of increases in gene expression across multiple adrenergic and sensory receptors in response to exercise challenge tracked directly with the severity of reported symptoms of physical fatigue, mental fatigue, and pain experienced in those with ME/CFS in the post-exercise period. Another follow-up study evaluated persons with ME/CFS and healthy controls matched by aerobic fitness with an exercise bike challenge, measuring serum before exercise, as well as 15 minutes, 48 hours, and 72 hours after exercise challenge. The investigators focused on the most statistically significant post-exercise gene expression receptors evaluated in previous studies, including metabolic, adrenergic, cytokine, glucocorticoid domains, and directly tracked these variables against patient-reported symptoms of pain, fatigue, mood, and confusion to hopefully elucidate a correlation between gene expression and these clinical symptoms. The largest increases of post-exercise transcription of receptor mRNA were found within alpha-2 adrenergic and glucocorticoid NR3C1 receptors. Furthermore, particularly significant correlations were identified between NR3C1 expression and overall symptom exacerbation, possibly suggesting that this glucocorticoid receptor may also play a role in post-exertional malaise. One hypothesis posits that this receptor's upregulation could alter cortisol sensitivity during PEM.
Neurobiological changes have also been observed during episodes of PEM. A 2017 study investigated the relationship between a resting state and post-exercise-induced PEM by evaluating performance upon several cognitive tasks, by imaging the brain with functional MRI, and by patient-reported symptoms. 15 female controls and 15 females with ME/CFS were asked to perform subjective symptom assessments and to perform 3 tasks, including a fatiguing cognitive task, a non-fatiguing cognitive task, a non-fatiguing motor task, while undergoing fMRI scanning both 1 week before and 24 hours after an exercise stressor. Those with ME/CFS and healthy controls had similar and matched physiological responses to exercise. Healthy controls displayed performance improvements by way of making less mistakes on their paced auditory serial task addition, or PASAT tasks, after exercise challenge compared to before exercise, suggestive of learned task improvement. However, those with ME/CFS made more errors and experienced a significant decrement in performance from pre-exercise to post-exercise testing.
This decline in performance was accompanied by a significant increase in post-exercise brain activity, most notably within the inferior and superior parietal and cingulate cortices. Furthermore, the magnitude of changes in brain activity in the post-exercise state were directly correlated to the number and magnitude of patient-reported post-exertional symptoms. By way of contrast, no significant brain activity responses were noted among the non-fatiguing cognitive task of serial number recognition or with a non-fatiguing motor task of finger tapping. This data led investigators to suggest that symptoms of PEM could be linked to detrimental neurophysiological effects. Among these detrimental neurophysiological consequences is mounting, though not definitive, evidence for neuroinflammation within ME/CFS, particularly within episodes of post-exertional malaise. Neuroinflammation, in this instance, is defined by microglial cells moving from a resting state to a pro-inflammatory state with associated structural changes as well as functional adaptations, including a local release of pro-inflammatory cytokines such as IL-6, TNF-alpha, and interleukin-1 beta. The presence of these cytokines in specific regions of the brain can lead to a cytokine-induced sickness response, with associated symptoms of heavy fatigue, brain fog, confusion, malaise, and low motivation. In healthy individuals, microglial cytokine release appears to be a transient process meant to occur during, for example, an active infection. Injection of bacterial lipopolysaccharide into the CNS can temporarily induce this neuroinflammatory response, though the microglial cells will rapidly recover to their resting state. In ME/CFS, however, there is mounting evidence supporting the hypothesis that microglial cells are not only easily and abnormally activated, but that these cells appear to be either stuck in this activated position or alternatively are possibly flipping back and forth very rapidly from inactivated to activated. Magnetic resonance spectroscopy is now being used to quantify several metabolites of neuroinflammation within the brains of those with ME/CFS. For example, lactate has been found at levels 4 times greater than in normal controls throughout many locations of the brain, including the ventricles, corpus callosum, occipital cortex, and perhaps most notably within the anterior cingulate cortex, a region known to be intimately tied to the sickness response and to imparting feelings of malaise and depressed mood. This finding is particularly notable because brain lactate only becomes elevated when neurons run out of glucose and when astrocytes begin to produce lactate as an alternate energy source, an extremely rare occurrence usually associated with significant vascular or malignant pathology. Choline, a marker for abnormally high neuronal cell tissue turnover, is also noted to be particularly elevated within the left anterior cingulate cortex of those with ME/CFS as compared to controls. A technique called brain thermometry, designed to assess for brain areas under excessive metabolic demand, has shown that those with ME/CFS have such a ravenous metabolic demand that their brains were measuring, in total, about 1 degree hotter than the brains of controls, with the bulk of this metabolic activity tracking to the very same locations in which lactate and choline were found to be elevated. Positron emission tomography is also being used to measure a radio-labeled isotope ligand to the translocator protein, or TSPO, a microglial cell receptor protein whose expression is magnified when microglia enter their activated cytokine-releasing state. Elevated TSPO levels on PET scans signify activated microglia and have been observed in the thalamus, the cingulate, and the hippocampus, the same regions of the brain found to have elevated lactate among MR spectroscopy studies. Activated microglia were also found within the midbrain and pons of those with ME/CFS, though the implication of this data is unclear. These studies all support the growing hypothesis that microglia appear to be primed or hypersensitized within ME/CFS, and that these microglia may react to very minor triggers in a robust manner. As of 2021, studies are actively underway to discern if large discrepancies within these same metabolite markers exist between rested ME/CFS individuals and those actively experiencing post-exertional malaise.
Not only have localized brain areas shown evidence of neuroinflammation and abnormal function, we are beginning to recognize disruptions to usual healthy patterns of neurobiological activation networks, such as the default mode network in the brains of those with ME/CFS. The default mode network is a collection of brain regions that simultaneously activate in a coordinated fashion when the brain has no external task to perform and is thought to be involved in self-referential thought, mind wandering, social awareness, affective processing, and goal-directed behavior. These regions become deactivated and quiescent when the brain switches from rest to the performance of a cognitive task, activating other brain regions associated with the performance of that task.
The default mode network can be evaluated using imaging techniques such as blood oxygenation level dependent scans, or BOLD scans. Evaluation of the default mode network in those with ME/CFS has shown lower resting neurological activity in all posterior nodes of this network, both before and after exercise. However, strikingly elevated neuronal activity has been detected in the medial prefrontal cortex of the brains of those with ME/CFS, as compared to before exercise, whereas this brain region would show decrement in neurological activity after exercise in healthy controls. The medial prefrontal cortex is actually the primary anterior node of the default mode network, and its abnormal activation after exercise appears to represent an uncoupling of this node from the rest of its neuronal network. It is believed that this uncoupling may be a pathological consequence of exercise in those with ME/CFS, and some have even proposed this clinical feature to be used as a biomarker for ME/CFS. Clinically, it remains critical to remember that PEM is perhaps the most debilitating and miserable aspect of the entire spectrum of ME/CFS as an illness. It has been postulated that the neurophysiological responses taking place during PEM may accrue over time, leaving a permanently altered function or injury upon exceeding some threshold of frequency and intensity of these effects. How then can we, as clinicians, manage this particularly insidious and simultaneously deleterious aspect of this illness?
The answer appears to be, at its most simplistic, through a careful regimen of both physical and cognitive pacing, so as to avoid entering the physiologic state we describe as post-exertional malaise. Fighting or pushing through the physiological thresholds of this illness consistently proves to be a fool's errand, often resulting in greater degrees of functional impairment and illness progression. Forcing continued, repeated, and exertional exercise to combat an underlying decompensated state, while logical at first glance, only appears to tragically promote worsened long-term outcomes.
Consider a stubbed toe. Slamming a toe with force into a doorframe may not be a particularly pleasant experience, but if given time without repeated injury, this toe will more than likely heal. Now consider a situation in which a person continues to stub the same toe repeatedly each and every day, or alternatively, once every 1 to 2 weeks for the next 10 years. Might there be a more permanent injury or scarring with this toe? It appears, upon a metaphorical level at least, that the same concept of injury and permanent alteration of structure and/or function may be true with post-exertional malaise.
A patient does not manage this illness by fighting harder, but instead by acting with discipline and calculated intelligence so as to prevent episodes of post-exertional malaise.
Strategies for pacing can be employed in many forms. Patients should be encouraged to take frequent restorative breaks within the context of even one particular activity, rather than completing a more prolonged activity and then resting for the remainder of the day. Setting timers during activities can be of enormous impact to this end. Wearable devices that track heart rate may alert a patient to heart rate increases that suggest physiological stress with an activity prior to onset of symptoms resulting from this physiological stress. Activities can be modified to reduce overall physiological stress. Consider suggesting that patients sit or keep their legs elevated when performing activities they might otherwise be inclined to perform standing, especially in those who suffer from notable orthostatic intolerance. The use of a simple shower chair can often mean the difference between an episode of PEM or a restoring shower. Remember that cognitive exertion need not be completing difficult algebraic calculations. In fact, cognitive exertion can often be the result of processing multiple sensory signals at the same time. Consider a person having a conversation in a crowded restaurant, dishes clanging, music playing, multiple conversations taking place, and delicious smells wafting through the air. While healthy people might find that maintaining a conversation with the dining guest in front of them may be easy, sorting through multiple sensory inputs to pay attention to one particular signal remains a particularly energy-demanding task. Reminding patients that particularly stimulatory environments alone can be enough to overwhelm their cognitive faculties can often be invaluable advice. Even emotional responses, be they excitement when opening a gift or mourning the loss of a good friend, can be a triggering event for post-exertional malaise, unavoidable as these triggers may be. While pacing remains the cornerstone for management of PEM and for ME/CFS in general, low doses of the opioid antagonist naltrexone have shown pharmacological promise. Low-dose naltrexone, or LDN, has been found to modulate microglial cells, perhaps through toll-like receptor 4, to suppress transition from resting state to an activated state in which pro-inflammatory cytokines are released. LDN is a widely used off-label treatment within the field of ME/CFS, seemingly increasing the physical and cognitive threshold for induction of PEM, shortening the duration and symptomatic severity of PEM episodes, reducing levels of widespread pain amplification and sensitization, and/or promoting an improved sense of well-being among a subset of patients suffering from ME/CFS. Finally, many medical providers have found it useful to remind patients that successful clinical interventions, say, to improve orthostatic intolerance, might improve a patient's overall feeling of wellness.
This sense of wellness can be subtle, but may still allow someone with ME/CFS to do more than they usually might be capable of. They may find themselves exuberant in a short moment in which they feel healthy or try to make up for lost time. Though these reactions are inherently human, they may cruelly still be enough to trigger an episode of PEM. Both care providers and patients alike must keep this concept in mind when assessing the actual efficacy of any intervention made to improve the symptoms of those suffering with this devastating illness.
Ultimately, it is critical that healthcare professionals and patients recognize PEM and work together to interrupt a repeated push-crash cycle. It has been consistently observed that when patients finally break this cycle and avoid PEM for a more consistent period of time, their functional baseline and all aspects of their ME/CFS symptom control improve, independent of any other pharmacological or behavioral intervention. Managing each and every pathological component of ME/CFS not only reduces the impact and suffering of those specific symptoms, but perhaps more importantly, can reduce the incidence, duration, and intensity of PEM and improve overall function and prognosis.
This video was made possible by the OMF-funded Medical Education Resource Center at BHC.